Well, today I'm going to do a little bit more than just a telehealth 101 because it seems like people are kind of after implementing and experimenting with it during the pandemic. I think we're ready to probably jump to the next level. So I'm going to talk about more like a 5-step way to quickly implement, which was incredibly important during the height of the pandemic. Not saying we're out of it yet, but there are still people that are hesitant to get started with telemedicine just because they don't know what's going to happen after post-pandemic, in terms of reimbursement and that type of thing. So there is still some hesitancy, and we'll talk a little bit about that as we move through these slides. As mentioned, I am project director for the Heartland Telehealth Resource Center, which is a federal program, a federal grant program from HRSA, and we are one of 12 throughout the United States, and we do a variety of things such as presentations just to get people familiar with telehealth. We do some telehealth assessments that help organizations look at their organizational readiness, their technology readiness to implement such a program. We mostly focus on rural and disproportionate population areas throughout the United States. But during the pandemic, we helped anyone and everyone that needed that kind of help to implement. We also have templates that for policy or protocols or workflows that help organizations so they don't feel like they're reinventing the wheel when they start out with a telehealth program, so that it's all just kind of there for them to put their own mark. And I will say that, there's just not really a toolkit to develop a telehealth program for every organization, because I've always said that when you see one telemedicine program, you've seen one telemedicine program, and it's not a one-size-fits-all, because each organization is just a little bit different. They may be working with different populations. And so it's important that we listen to those organizations when we provide this assessment so that they can implement the telehealth program that's perfect for their organization. So here's a map of the telehealth resource centers. Of course, we're smack dab in the middle there. We serve 3 states. Luckily, we just have 3, Missouri, Kansas, and Oklahoma. Some of the others have quite a few states to serve, or quite a large geographical land to get around in. I feel pretty lucky with our setup here. There are 2 national telehealth resource centers as well, above the 12 that I had mentioned. And one is for policy. That's the CCHP that you see in the bottom corner left of the slide. And then the next one is the TTAC, which is the Technology Center. So the policy one, of course, deals with telehealth policy and regulation, and they publish a 50-state compendium of what's going on in all of those states, as well as they keep a good finger on the pulse of what's going on federally. And then TTAC is there to help organizations kind of vet some of the technology that's out there, because it's really nice to have a partner that's not trying to sell you something, all right, and that you don't fall into something that maybe you can't afford, or that's too much for the organization in terms of what it can do. Sometimes it's simple is best. So TTAC is a great resource. They have some pages on their website that actually compare, let's say, digital stethoscopes, so that a provider could go and look and see which one might work best for them. So it's an excellent resource. And if you could go and look at those national resources by just going to the telehealthresourcecenter.org website and click on either the CCHP or the TTAC or any of the 12 telehealth resource centers, just to take a look and see what they have available. First of all, I just want to thank you for all the work that you're doing during the pandemic. If you are assisting patients, seeing patients, thank you so much. Your work has not gone unnoticed, and you guys are on the front line, and it goes without saying that without your ability to see these patients and the grace that you provide the families. My family's going through something right now. My mother-in-law is on hospice, and we cannot go in and see her. And the end is nearing, and they can hold an iPad up, and I know that the healthcare workers that are with her are doing the best they can to help the families through this, but it is it's heart-wrenching for the families, but I can't imagine doing this every day like some of the healthcare workers are doing. So thank you very much. So telehealth. Well, I had quite a little, I work from home, I'm remote. I have been before the pandemic, and then the pandemic hit, and telehealth, of course, the questions, the interest went through the roof. It's not to anyone's surprise that we have actually gone 5 years ahead of time into telehealth than we would have normally done without the pandemic, just because everybody was interested in it. People were dabbling in it. People had interest, but didn't really want to implement yet because the reimbursement wasn't there, or they didn't think their patients would like it. Lots of reasons. And then when the pandemic hit, telehealth became a lifesaver for many professionals as well as patients. And I would love to say that it looked like a real organized type of, thing, that if you've ever been to a horse race, people they're matching colors with the jockeys and the horses, and it's, organized, and it's beautiful, and it starts on time, and that type of thing. And there might be a little hiccup here and there with one of the horses, but usually it's, what pageantry. But when telehealth started during the pandemic, it looked more like the bottom picture. It was a wild horse race. People were getting into it. They wanted to implement right away. We were used to helping people implement in a strategic process, and that we had to throw that out the window because they wanted to implement fast and furious. I have a son who is a pediatrician in Kansas City, Missouri, and he called and he said, "Mom, we want to do some telemedicine. We don't know what we do, but we want to start Monday, and this is Saturday." And I was like, okay, well, let's see what we can do. And they actually fully implemented what they wanted to, not by Monday, but by the end of that next week. And so, within 5 days, they had a telemedicine program. They had policies, and everyone was educated toward that. And that was quick. So like I said, we're going to skip the telehealth 101 and talk a little bit more about hybrid patient visits now, because as in especially a pediatrician's office, you combine a lot of virtual and in-person experiences, and most people are looking toward that post-pandemic. So we'll talk a little bit about hybrid. So what would a hybrid care model look like? Well, you would have to consider, who is interested in doing telehealth. What are those workflows going to look like? You have to look at the technology that you have, the technology that maybe you need to purchase, and engaging your patients into that type of telemedicine. If a patient doesn't know you have it, then it's hard to, fill those appointments. But if they know, and they don't know how, then you have to have staff be able to reach out and teach. I will say that consumers are demanding telemedicine now that they've experienced it. they really like it. Think about it. We can go to the bank, or we can sit at our desk and or on our laptop and go to the bank. We can do our banking online. We can go to the grocery store, or we can order it online and then maybe go pick it up or even have it delivered. Things have changed drastically in the past few years with technology, and healthcare has been a little bit slower to embrace some of these types of things that consumers demand. Telehealth has always been one of those types of services that consumers wanted, and healthcare providers were a little slow to, get to the race, let's say. And I always told healthcare providers that if you don't put skin in the game, okay, then you're going to probably lose patients to someone else who is implementing telemedicine. So it's important, at this point, to make sure that you keep your patients, keep that flow, you keep the patients in their communities, so that they're not going elsewhere, or they're just not going online to get care that is not consistent with being a one-stop shop. If you go to a teledoc right now and you download the app and you go to teledoc, that teledoc's not going to tell your primary care provider what's going on with you. And so that there's not that consistency of care there. The guiding principles of hybrid care would be that connection, integration, and collaboration, and making sure that the patient experience and outcomes are your ultimate goal. It's not doing telemedicine for the sake of doing telemedicine. It's providing telemedicine so that you can continue to have really good patient outcomes. So the first step would be to make a plan, bring a team together. It's never a good idea to have someone in an office by themselves planning telemedicine for the entire practice, okay? You have to bring the team together and decide what you're going to achieve. And a quick organizational readiness assessment is quite appropriate. Do we have a champion? Do we have the equipment, or are we going to have to purchase equipment? Are we going to, do we have the leadership to do this? And it's a little like, a strategic planning cycle, but only really quickly if you're trying to implement quick and on a shoestring. So you look at the goals, you make sure that you're doing what it is that you set out to do, that you have some outcomes, that you have some strategies to get to those outcomes, and you have some benchmarks that you can measure so that you can certainly hold those up to a board, to leadership, that type of thing, so that your telemedicine program's working.
Janine, what's a champion?
What's that?
What do you mean by champion?
A champion for telehealth is, we always say that it's not going to work unless you have someone driving the bus, okay? And it's someone who really believes in telehealth and wants to make it work. If you do not have that in the organization and everybody's sitting back going, yeah, I'm not so sure this is going to work, it's not. So you've got to have somebody there that's going to really push and check back and make sure that the telemedicine program's working. That's a great question. So the people to keep in your circle or around the table, I like to say, would be, of course, the healthcare providers who are interested in providing the telehealth, but other professionals too in the practice or the organization that would be utilizing telehealth. Clinical director, of course, the billing office. Do not forget the billing office, because that's where your revenue is going to come from, and they need to know how to code and what we're going to code and who we're going to work with. They are incredibly important. It's important for your schedulers to be at the table and not just be told, hey, this is what we're going to do, because I'm going to tell you something, it can make or break your program. If the front face of the organization who answers the phone or whatever, they have to know what's going on, how to make that telemedicine schedule work, and not say, oh, you have one of those appointments, I'm not quite sure about that, you know. So you've got to have them really promoting the program for you as well. Of course, you've got to have IT, and if you're lucky enough to have someone who does some marketing or who updates the website, okay, get somebody there who can do some little bit of marketing. So then the second step would be to assess and do just a little bit of research. So people around the table, what lines of service are you going to deliver? And is it going to be just one type of visit, or are you trying to do everything? And my advice is always to start small, okay? Start with one line of service and build upon it, get some success, and then add another, because nothing is going to make or break a program more than having too many irons in the fire and everybody's a little bit confused about who to send who to where when it comes to a telemedicine appointment. So we've got to research the reimbursement rules and find out what's going on and how to code that for your state. All states are different, and so it's important that you look at your state and decide what Medicaid's doing. Federally, Medicare opened what I call the buckets of reimbursement when the pandemic hit, so they're doing some great things. And also our private pay or commercial insurance followed along. Some of the commercial insurance now, they're starting to pull the reins back in a little bit on telehealth, but I think once they take a look back and understand, and if they hear from you that you're still wanting to offer this, that they will probably still come along with you for the ride for telehealth, because it is something that they're finding. I know that I just talked to Blue Cross Blue Shield here in Kansas last week, and they're getting ready to even put out a grant proposal for healthcare providers in the state of Kansas to purchase telehealth equipment because they see the value in it. I couldn't believe it. I mean, I really couldn't believe it when I had a commercial insurance call and say, hey, you know, we want to help more with telehealth, because they are the ones that were like, no, you know, our members can't afford this, and I'm going to have to, we're going to have to put more money into this, and we're not willing to do that. But all of a sudden now they've got money to provide to providers. So you might want to keep your eye open for opportunities like that, because they probably are not going to be the only one doing that. When you assess the lines of service, you look at what kinds of appointments are appropriate for telehealth, and are you going to do these by televideo and or telephonic. So actually, I had the hardest time before the pandemic saying telehealth was not telephone healthcare. Okay, some people still would say, hey, that's just telephone, we don't get paid for that. Well, during the pandemic, you're getting paid for some telephonic appointments, and there are codes that you put on there. So you have to look. And a lot of times that is very appropriate for those areas in the state that don't have really good broadband and that might drop televideo. So it's important that you are getting paid for something like that. If a televideo appointment is scheduled, they get on, but then it drops, you can always finish by telephone and still get paid. What kinds of peripherals are really not appropriate for home telehealth right now, because not everybody has that equipment in their home. But if there are some places that, like a satellite clinic that a practice has, that patients come to that clinic to connect to the doctor elsewhere, that there may be the need for peripherals. So there may be the need for digital stethoscopes or exam cams. And then what appointments must occur in person. So that's something that the committee can work out. So let me just go through with some of the primary care clinical use cases for telehealth. You can definitely work with patients who have some of these chronic diseases and treatment plans that maybe they need to be monitored frequently. Their medications can be adjusted or managed by telemedicine. There are follow-ups that can occur by telemedicine. And so that is not, you know, something that they have to come in for all the time. And they're really appreciating that. Some of our patients with chronic care problems, of course, love the fact they don't have to go sit in a waiting room and be exposed to not just COVID, but other viruses as well that are still out there. So wellness exams are also really good use case for telemedicine, as well as, like I said, follow-ups. I think I worked with an organization that says, we're just going to start doing telemedicine with follow-ups. And it's like, great. Okay, let's get our feet wet a little bit, do those follow-ups. And then, you know, once you get comfortable with that, then we can expand your lines of service. Providing those results that need to be talked about and discussed are also a really good way to utilize telemedicine. This is just a slide that kind of goes through an annual wellness visit via telemedicine. As you know, an annual wellness visit has, you know, the provider's asking lots of questions. There may be a health risk assessment that has to be filled out. You're talking about medication reconciliation. Maybe this is not the only doctor the patient is seeing, so they need to find out what other medications other physicians are prescribing, and just lots of screenings that can be done very well by telemedicine. And by following this little step-by-step guide, someone can actually get paid for a wellness visit that they really fell off during the pandemic. People weren't going to the doctor just for their annual wellness visit. As I mentioned before, the three buckets of reimbursement are Medicare, Medicaid, and private. Those private payer laws vary by state, as does Medicaid, as I mentioned. But this slide is important because you can go directly to the Center for Connected Health Policy and look at current state laws and reimbursement policies. Sometimes when you're looking or you're talking with your state and saying, well, you know, why can't this be covered? You can look at other states and say, well, you know, other states cover this, you know, for telemedicine. Maybe we could too. And this is why I think that is the case. So keeping those lines of communication open is very, very important. I don't have a list of what private and commercial payers give because they're all a little bit different. And my best advice to an organization in practice is to make sure that the billing office has an open line of communication with that representative from each commercial payer, and making sure that you know how to code and what to put on that, because sometimes that varies even from Medicare to Medicaid to the private payer. So step 3 is to take a look at the technology needs. A detailed technology plan is really important. What do you have on hand? Do you have a laptop? Is it going to be something that's moved from room to room? Or is the provider going to sit in front of his desktop? And, you know, is there a camera on that monitor? Do we have good sound? That type of thing. So there's lots of things in a technology assessment that the TRCs can help with and make sure that you're getting a detailed technology plan. Some of the laptops that are out there now, you know, most of them have cameras, but I think if you watch some news programs, because a lot of people are being interviewed at home now, you you know, they may be looking differently when they're talking on their laptop, because most cameras are at the top of the monitor, but some of these new laptops are coming out and the camera is at the bottom of the monitor. And if you look at the bottom of the monitor, look at what I'm, you know, we teach people to look at the camera when they talk, because that's, you know, better eye contact. But looking at the bottom camera, that's not going to do it. It's better to look up than it is to look down. So there's just a lot of tips and tricks too that we can help people when they're looking for the type of technology that they're going to need. These are some free and low-cost telehealth platforms that came out during the pandemic that said, hey, try us out, okay? We're going to give you free access to this, or we're going to give you a reduced cost, or a 60-day trial. And so all of these were platforms that people could use, and they really have helped get things going quickly, because you could go on and experiment with them online and find out if that was going to be easy for your organization to use. Video platform trends are, of course, they're web-based, as you can tell by the links. They're, it's a link now. It's not an app that you have to download in order to get telemedicine. So that's really important to understand as well. Direct to patient in home is something that's really important to understand how a patient is going to be able to get on the link from home. I worked with one FQHC that said, we are having the biggest trouble with our telemedicine program because the first part of the appointment is used to help them get on the technology, okay? So we're on the phone with them and telling them to click on the link, and they can't find the email or the text that was sent with the link. And, you know, so the best case scenario for something like that would be to have a staff member dedicated to calling and working with telemedicine patients if it's their first time the day before the appointment. So you can iron all of that stuff out so that when the appointment starts the next day, they're ready, they're in a quiet place, the TV's off, they're not eating their lunch, they're not driving. So it's important to, you know, educate the patient about telemedicine. Not only are we talking about educating providers about how to deliver telemedicine, but now the consumer needs to be educated as well. And it is certainly helpful if they know how to get that link and get that appointment going at the time, so that the provider's not running behind all day. Infrastructure is still something that we have to talk about, and there are some practices that are in areas, some of our Indian reservations, the tribal Indian health, don't have the sufficient bandwidth necessary, because a lot of times they're just really in remote parts of Oklahoma and Kansas that it's hard for them to get. There are ways that we can work with the internet provider that can help with that. There are boosters that they can do. There are ways that they can increase their megabits per second so that they can actually hold a televideo conference. So there's some ways around it, and sometimes there's no way around it, because sometimes it is just one of those dead spots. And I know that there's a lot of funding out there now from the FCC and USDA that are really trying to work at increasing broadband in our rural and frontier areas. There are a lot of factors to consider when you're talking about broadband: how many people are on broadband at one time, and the hardware. I mean, is it up to date? Is the software up to date? Do you have enough storage for your technology? And one of my favorite stories, and this was just 5 years ago, it wasn't really that long ago, that a private telecom company provided the internet for a small rural town, about population 3,000. And they wanted to do telehealth, and they were trying to do telehealth in the afternoons. and they were not having success at all with telemedicine. The televideo kept dropping, and they didn't know why. Came to find out that it's because school was out and all the kids went home and started gaming at the time that these telemedicine appointments were being held. And so it's like, okay, you know, they were really putting a stress on that community internet. And so they had to, you know, figure out another way or another time to provide some of those telemedicine appointments. It's always best to hardwire a telemedicine equipment, especially in those areas that may have kind of spotty broadband or technology, because Wi-Fi is going to be somewhat great for speed, image, and quality in places that have robust broadband. But if not, then relying on that Wi-Fi is not going to make a good telemedicine visit. So it's important to plug in, and usually people get a better result when they do that. Plug in. Again, you don't need to purchase excessive amounts of equipment to start a telemedicine program. You do not need a robot, as pictured here. One of our best clinics that we helped implement was an ALS clinic in Wichita, Kansas, that actually the neurologist was at KU Med. And so what we did to connect is they had tablets, okay? And so we just fashioned a tablet on top of a pole that's almost like an IV pole, but it really is it's a cart of some type. It had a basket at the bottom. And so we just wrapped Dr. Barron's coat around it and a stethoscope and said, okay, here's virtual Dr. Barron. And he would talk with the patient that way from Wichita, so that that patient would not have to drive 3 hours to the med center, find parking, maybe spend the night, you know, everything that goes with traveling with somebody with ALS, which is never easy. They were quite grateful for the fact that there was a telemedicine program, that they didn't have to go to the doctor there. We also brought all the ancillary services to them, so that they had a 3-hour appointment once a month. And the dietitian would come and speak with them for 15 minutes, and then maybe their PT would come in and work with them. We had the medical equipment guy, the wheelchair guy, come in, take a look at the wheelchair, make sure that everything was working appropriately. The speech therapist was there for another 15 minutes. So all those ancillary services wrapped around that patient there at the location in Wichita. And then the neurologist, Dr. Barron, would speak with the team and the patient. It was an excellent way to provide telemedicine to patients that are pretty difficult to travel with. Here's some equipment, and you know, a picture of an electronic stethoscope, an exam cam. This exam cam, I think this one is the horoscope. It's pretty cool. You can detach things and put like a mouth cam on it, so that you could use it for dental care, or you can put an otoscope on it. You can do a lot of different things with that, and it's very high powered and an excellent camera. This one at the top right, where it says at home devices, it's known as Tyto Care, and it is designed for to use on a cell phone. Okay, so a smartphone, you can attach that otoscope to the camera portion of it. You can attach the stethoscope to it. You don't have an exam cam because you can use a phone camera for that. So right now, that is being sold at Best Buys across the country for around $199. Okay, I would say that it's not too far off to think that most homes will have that available to them, just because of the convenience. And you can, you know, look in somebody's ear, You can have them do the stethoscope. It would help, you know, physicians tremendously to be able to do some of those exams that are used in an in-person visit. So that is something that, of course, remote patient monitoring is huge now, where it's a little bit more than that. They may have a digital weight scale. They may have maybe oximeter, that type of thing that they can measure oxygen levels, and they do that in a remote basis so that they can keep data on those patients and keep a good record of what's going on with them. So telemedicine equipment and space, of course, like I said, you don't need you know, a robot. A desktop or a laptop, even a iPad works. You just need a webcam with some good audio. It needs to be private. You need to have good acoustics, and it needs to be comfortable and hopefully not look like this. So step 4, make a plan. So a detailed plan, implementation plan, is really important because you do have to have good protocols. You have to have those guidelines in place and policies, and then that workflow so that people know what's going on and what type of patient they're going to refer to, certain appointments, what providers, that type. Develop performance monitoring plans so that you can have some patient satisfaction and monitor some benchmarks so that you can tell your story. And those resources that you can get that from, you know, Heartland TRC or the Telehealth Resource Center.org. We can help. And then you can also go online and look for a lot of these tools that we've talked about. Then it's implementation, and that's the fun part, right? Everybody wants to get to implementation, but it's really important to look at all of those steps leading up to implementation so that it is a good program, it's seamless, and that things go smoothly. So COVID and telemedicine, again, I think we talked a little bit about how treatment or prevention services, education services can be provided through televideo or through the phone. You know, like an iWatch or a Fitbit, those types of things would be mHealth type equipment that some people have that physicians may want to look at that. And then the social media aspect of providing and promoting your program is critical and important. A lot of people say, is telehealth going to go away after the pandemic because, you know, people are going to come back to the office now and be seen in person? But I will argue that telemedicine is not going away. And even before the pandemic, and some of you may have toured this facility. If not, it's in Chesterfield, Missouri, but it is Mercy Virtual. The CHI Foundation built this $54 million building a few years back, and it is the first hospital with no beds. Doctors and nurses go to work there every day to see patients, but the patients are in their own homes or elsewhere instead of going to this building. And they do a great job of remote patient monitoring. They've saved this hospital system millions of dollars in catching problems before they happen, okay? Changing medications on people with COPD before the person with COPD even knew there was a problem. And it was all because of the data that was being downloaded from their remote patient monitoring equipment. So they've saved on 30-day readmissions, they've saved on emergency room visits and that type of thing. So at the root, I always like to talk about this slide just quickly. You know, it takes a good root system for a tree to flourish. If there's not a good root system, that tree is not going to do well and may die, just like a telehealth program. There's a lot of behind the scene efforts that go into preparing for a telemedicine program, up to implementation, up to sustainability even. So there are all of these types of issues or topics that you see in this root system have to be taken care of in order for that telemedicine program to thrive. So it's kind of fun to get on televideo and think, oh, we can do this, but there's so much going on behind it. You've got to be able to map that out. So I'm going to go through these really quickly, but workflow is something. I worked with another FQHC that said, we are having a heck of a time with our telemedicine program, and our patients like it, our providers want to do telemedicine, but we're having a difficult time. And it just happened to be because they didn't have a good workflow. There wasn't a way to help others in the organization understand what appointments were good for telemedicine, and then who played what role. They were getting confused with, a provider needing to provide the technical assistance for the technology instead of doing the healthcare. So there is a great way to do workflows, and that is that you get around the table with everybody who has a part in the play, so to speak, and you ask these questions. Walk me through your typical telemedicine appointment. What does that look like now? What are some of those barriers? What needs to happen in order to improve this process? Who's the decision maker? Okay. And what you can do then is map out these workflows that will define the tasks and the order in which they occur. Who does what? And then create this visual document that is posted somewhere that everyone can get a hold of it or look at it when they're going through this process. I'll skip that one just for the sake of time, but here's an example of a virtual visit end to end, okay, for the patient, for the support staff, and for the provider. And then you can break them up and make even workflows that are just a little bit more, intricate to make sure that every step is taken in these virtual visits. How to conduct a telephone visit, okay? So the check-in and then what the provider does. So all of these are available on this presentation, which I believe you have a copy of, but if you need some additional information about workflows, the Telehealth Resource Center certainly has that. All right, as we wrap up, the lessons learned. We talked about equipment doesn't have to be the most expensive. Learn from others. If there are other practices, other providers that are doing telehealth, learn from them and see what you can glean from how they do telemedicine. High satisfaction scores from children to the elderly have been given for services. A lot of times we have these preconceived notions that a certain group of people is not going to like telemedicine, and we couldn't be further from the truth in terms of that. Also, just remember, hey, this is still medicine. Technology is just the tool. It's not something that we have to, go to school for. We don't have to have a certification for telemedicine, even though that's starting to become a thing that you can get a certification, but it's not necessary. And also, I think that might be a barrier for some people because they just don't have time to do that kind of thing. Plan and practice for telehealth, and then make sure that you understand that telemedicine is certainly a process and not a destination. So you can learn more about telehealth at telehealthresourcecenter.org. And you can join our Telemedicine Echo. Actually, next week, Tuesday, February 9th, we are going to have a presentation of a didactic on school-based telehealth from Oklahoma, and then we open it up for questions. This Telemedicine Echo just assists people in understanding more about how to implement and what types of lines of services are available. And school-based telehealth is certainly something that is becoming a lot more popular. Also, the National Consortium of Telehealth Resource Centers holds a webinar every month February 18th is our next one, telehealth policy update. And so it's really going to talk about Medicare and the feds, about what's going on and what we're seeing. And so please join us at 1 o'clock Central Time. You can register at telehealthresourcecenter.org. And so I'm open to any questions that you might have. We have a few minutes for questions, and happy to answer anything that you might not have understood.
I have a question really quick.
Sure.
So I apologize if we already covered this. I came in a little late, but I know that over the course of COVID, there's been a lot of drop or altering of the restrictions and rules with telehealth and who can provide it and the various steps. Do you think that those are going to be removed and the previous restrictions will be in place once the pandemic ends? Do you think they should? I'd just like to hear your opinion on that.
Oh, you know, I think what the best thing that happened during the pandemic is we realized that there are a lot more healthcare providers that can utilize telemedicine than those that are being paid for right now, such as physical therapists, occupational therapists. Some states do not reimburse dietitians. And think about the diabetic education that can go on via telemedicine. And even, you know, we had a telemedicine program. It was a grant at some point where a dietitian did a cooking show and connected with patients at home, and they could cook along with her. Okay. And so they'd have their iPad in their kitchen, and this was one of those types of projects that was just loved by the patients that were going through new diabetic education. And so, yeah, I am hopeful, but just remember that a lot of people that make decisions, our legislature, that make decisions sometimes for our state reimbursement, even our national reimbursement, have no background in healthcare. Okay, so it's so important that you start now, and that is to talk with your representatives, state, local, national, and let them know what your experiences are with telehealth and how you can reach patients and what the outcomes are and why it is so important that this type of service is available, especially in rural and underserved areas. Most people have a smartphone, whether, you know, we realize it or not. Most people have a smartphone, and they can connect with a provider that way for telemedicine. And I think the education that could occur with some of the APRNs or health educators, even community health workers, could be tremendous and help with patient outcomes. Because we have, you know, an epidemic of chronic care problems throughout the nation. And I think hopefully that we'll be able to shed some light on this with everything that we have accomplished during COVID in experimenting with telehealth and actually implementing it. Good question.
Thank you.
Janine, I have a question. So the facility in Chesterfield, where it's all like virtual appointments, is that facility in like do they talk to local hospitals? So if a patient really does have to be admitted, and if that patient information, that data can be given to that hospital, like so that the flow or the admission can be a smoother process?
Yeah, and so, of course, you know as well as I do, the Mercy system is huge, and it crosses state lines. It goes to Arkansas, Oklahoma. It's kind of a four-letter word in Kansas because they've pulled some of their hospitals out of the small communities along the state line. And so I have to be real careful when I talk about Mercy in Kansas. But they have a hospital system that's far-reaching, and so they do have even EICU with some of these smaller hospitals that are associated with Mercy. So if they're associated with Mercy, yeah, it's all one medical record. You know, if it's not, then you know, they're probably not reaching out to those types of hospitals.
And then one last question. So the Telehealth Resource Center, are there resources for rehabilitation, just like ideas on how to conduct, I don't know, an appointment, or just even like activities that you can do via telehealth?
Well, I happen to be, are you talking like for physical therapy,
Yeah, or like
rehab?
occupational therapy,
Yeah.
speech therapy.
So right now, physical therapy is allowed in some states via telemedicine. Right now, I'm on a research study that I'm helping a professor and some research assistants in working with other PTAs, okay, physical therapy assistants, which is what most rural communities have. And unfortunately, they don't have PTs. They might have a PTA, an assistant. That PTs can work with the assistant and the patient through telemedicine, so that, and it's for like an MS project, so a multiple sclerosis type patient. And so the PT that is an expert in that field at the med center connects with that patient and the PTA in order for that patient's outcomes to be as high as they could possibly be in a rural area without them having to travel for PT. So yeah, there, and I could connect you with a PT at KU Med to talk about how they're handling that. It kind of, unfortunately, it started before COVID, and then that kind of, you know, it's, yeah, a lot of things have happened because of COVID, or not happened because of COVID. Any other questions?
Thank you.
I was going to ask, just with the facilities that you've had the most success with, do they share any sort of characteristics? Like, what's the difference between a facility where you've really seen them made it work and ones where they weren't really able to get it off the ground, and were there any similarities there?
I think the similarities would be the ones that made it work had that telehealth champion that we talked about earlier. Somebody that was dedicated, that said, we're going to make this work. I'm going to devote some time to this, and, you know, energized others to make it work. In the ones that never got off the ground are the ones that just didn't have that champion, didn't have that desire to do telemedicine, even though they thought maybe they should. So,
All right, that makes sense.
yeah. And the workflow, you know, you cannot underestimate the power of that workflow to make it work. There's turnover, there's, you know, so you have to, it's a constant thing. Like I said, it's a process, it's not a destination. You continuously have to work on the program for, you know, new staff, maybe a new line of service, that type of thing. So it's always best if there is some part of somebody's FTE, okay, that can be funded for telemedicine, that there's somebody dedicated to that.